Hi there. It's me down here. My name is Matt. You may know me from the ambulance, you may not, but I'm going to be taking you through the CPAP training today, the lecture component, to make sure you have all of the knowledge background that you need on this new treatment that we're putting out on the ambulances very soon. So very, very excited, very happy to be taking you through that. And also very excited to see this this treatment actually get deployed on the ambulances, because it can do a lot of good for a lot of people. So let's check it out. The plan for today is we'll go over just some background knowledge that you need to have before we talk about the specifics of CPAP. Then we'll get into what the indications for using this are, the contraindications, and then we'll talk with we'll get into the weeds a little bit on our procedure for actually using this. The wording of the SOP is still being finalized, but in broad strokes, we'll go through what's going to happen when you actually go to put this on a patient, and what the equipment looks like, and how to use it. So after all that, you are going to have a chance to well, you're going to have to do a couple things. So you're going to have to go online. You're going to have to do a quick quiz that takes you through, asks you about some of the stuff that we'll have covered in this training. And then after that, you're going to meet up with me or with someone else who's been trained to train folks in CPAP down at the base. And you're going to have a chance to actually put this on a simulated patient, make sure that you're comfortable deploying it when needed, using it, make sure that in terms of the hands-on skills, you're all set with those, and we'll get you signed off. And then at a future date, once everybody's been trained, we will go live on the ambulances with this equipment. With that having been said, I'll let you know that Dr. Krupe, our medical director, has already approved this for us. He's approved our plan for training, and he's in full support of our deploying this. So we're good to go from that perspective. I will tell you that the equipment's already been ordered. Should be here soon, and we're looking to get this going in the very near future. I will tell you that winter tends to be the time when CPAP becomes most useful, and we'll talk a little bit about why that might be. But I think with the colder weather coming up, this is a really good time for us to be doing this, and so we definitely shouldn't waste time. So let us not do that. So the background you need to know: CPAP stands for Continuous Positive Airway Pressure. And I want you to remember that there are sort of two large components of the airway. You have the upper airway, which is the mouth and the throat and the nose. You have the lower airway, which consists of the trachea, bronchi, bronchioles, and alveoli. And when we talk about applying positive pressure to that airway, we're going to be applying it up here on the nose and mouth, and it's going to apply that pressure all the way down the airway tree, through the pharynx, the larynx, the voice box, the vocal cords, the trachea, down past the carina, through the bronchi, into the bronchioles, and then finally into the alveoli. And when we talk about positive pressure, all we mean very simply with that is that this is a force that's greater than the normal atmospheric pressure, right? So when we normally exist as human people, we exist in an atmosphere that is 1,013 millibars of pressure on average. That's just the weight of the air pushing down on us. And so when we are going to apply positive pressure to a patient, that's going to be pressure greater than that normal atmospheric pressure that the patient would be subject to. So when we normally breathe, right, it's a negative pressure process. So what happens is the diaphragm moves down, the chest wall moves up a little bit, and we create a larger volume in our chest cavity. That larger volume has lower pressure than the atmospheric pressure, and so air from the atmosphere rushes in to our lungs to equalize that pressure, right? And then as the diaphragm relaxes and comes back up, the chest wall comes back down, that air gets then pushed back out. And that's how we normally breathe, right? Hopefully this is a process you're familiar with. as a human person. For BVM ventilations, which is the closest thing that we currently have on the ambulance to CPAP, this is an intermittent positive pressure process. So with, again, normal breathing negative pressure, BVM ventilations is positive pressure, but it's intermittent positive pressure. So I'm going to increase the pressure, squeeze the bag, push air in, and then I'm going to let the air come back out naturally. But the only pressure that my only input there is positive pressure, right? But it's intermittent positive pressure. So I'm providing inspiratory positive airway pressure, but little to no expiratory positive pressure, or EPAP. With CPAP, the difference here is this is a continuous positive pressure process. So we are not in any way changing the way changing the rate, or really too much the depth of the breaths the patient takes. What we're doing is we're changing the pressure at which those breaths are taken. And you can see that on this graph up here. So as you look at this graph, normal breathing, you see the pressure going up and down rhythmically. And then with CPAP, you have the same rhythm going on, but it's taking place at a higher pressure. And we'll talk about why we would want that higher pressure to exist in just a second. So distinguish that from something called BiPAP, which is not something that we do. And with BiPAP, we actually change the pressures depending on where the patient is in their inspiratory versus expiratory cycle. That is not what we're doing. And there are certain times when BiPAP can be very helpful, but it is not within our scope to be doing for our patients. So we're just doing CPAP. And again, the characteristic of CPAP is that inspiratory positive airway pressure, or IPAP, equals expiratory positive airway pressure, which is EPAP. Okay. So why would we do this? What are the therapeutic benefits? Well, there's a couple things. So first, we can splint open alveoli that are swollen or constricted, as well as bronchi and bronchioles that are swollen or constricted. And this improves ventilation in the lower parts of the airway, right? So you can imagine a patient with asthma or a patient with bronchitis. They've got bronchioles and bronchi that are swollen and constricted. And when we apply pressure to those bronchi and bronchioles, it's going to tend to open them up a little bit. And so that improves our ventilation. It increases the volume of gas exchange a little bit, and it can help those patients breathe a little bit more easily. Okay, the second thing that it does, the second major thing that it does, is it can reopen collapsed or atelectatic, and that's going to be a term that you definitely want to remember. So atelectatic means something that has undergone atelectasis. Atelectasis is another word for collapse, right? So when the alveoli collapse in on themselves, they become atelectatic, and CPAP can reopen those collapsed or atelectatic alveoli, and that increases the area of the functional lung tissue, also called the parenchyma, that's available for gas exchange to occur, right? So if an alveolus is collapsed, there's no airflow over the surface of that alveolus, and gas exchange isn't occurring. If we reopen it, then that surface area becomes, again, available for gas exchange to take place, and so we can increase the amount of actual ventilation with the environment that's taking place. Okay, so then the third thing, so there are three primary benefits here. The third primary benefit is to force oxygen across the alveolar membrane. So this comes into play when we have edema, which is just another word for fluid. So when we have edema or fluid, or even pus that's built up in the alveolar sacs, and by increasing the pressure of the gas pushing on the alveolar membrane, we increase the rate at which it diffuses across that membrane, and that improves the oxygenation of the patient's blood. So those are our primary therapeutic benefits of CPAP. Splinting open bronchi and bronchioles that are swollen or constricted, reopening collapsed or atelectatic alveoli and preventing further atelectasis, and then finally forcing oxygen across the alveolar membrane and improving diffusion. Now, there are some side effects. So the biggest side effect that I want you to know right off the bat is that this increases intrathoracic pressure, and that results in decreased preload and decreased cardiac output. So I want you to remember from your BLS class, when you became a CPR provider, you learned that a side effect of excessive ventilation is not only gastric insufflation, but also a decrease in cardiac output because of the increase in intrathoracic pressure, right? We're increasing the pressure in the chest. What happens with that is blood has to get back to the heart in order to get pumped. If I make the pressure in my chest greater, the blood has a harder time getting back to my heart to get pumped. And in consequence of that, less blood arrives at the heart. The force of blood arriving at the heart is lessened, and that decreases my cardiac output. Now, this is actually helpful some of the time. So pulmonary edema, or a buildup of fluid in the lungs, is, as you would imagine, closely related to problems of fluid overload. So there are times when, if a patient's fluid overloaded, we'd actually like to decrease the cardiac output a little bit, because part of my problem is that the blood pressure is too high, right? So to the extent that you have a patient that's got super high blood pressure in acute pulmonary edema, the decrease in cardiac output can actually be beneficial to that patient. But if you have a patient who is hypotense or borderline, and you put them on CPAP, you're going to bottom them out, and you could kill them. So you can't do it. And so one absolute contraindication for us with CPAP is a systolic of less than 100. Now, I would be very judicious with how you interpret that. I think if you have a patient with a systolic of 104, I don't think you should say to yourself, oh, well, I don't have to worry, right? Be very cautious, because this can have a huge effect on cardiac output, and the last thing you want to be doing to an already sick patient is dropping their pressure. Okay, so other side effects. We have discomfort, we have pain. There's risk of a pneumothorax, right? So if we have a weakened area of lung tissue, also known as a bleb, we can rupture that bleb and end up with air getting pushed into and building up in between the chest wall. So that would be the parietal pleura and the edge of the lung, also known as the visceral pleura, and that is the definition of a pneumothorax, right? You have air building up in there. So that's not good. So you need to be alert to the possibility of a developing pneumothorax. And then if you have a patient who is at risk for vomiting, CPAP as well is not a great treatment, because if they do vomit, the continuous positive airway pressure is going to have a tendency to push that vomit right into their lungs, which is the last thing you want. So those are some drawbacks to CPAP. All right, so in terms of those were our side effects. In terms of some disadvantages to this therapy. So one, I think the first and most important one to be cognizant of is that we are not able to control our patient's respiratory rate nor their tidal volume when we put them on CPAP, which means as a result, we are not able to treat respiratory failure with CPAP. I'm going to say that again. You cannot treat respiratory failure with CPAP. I think it's important that we have a very clear understanding of the difference between respiratory distress and respiratory failure, right? Respiratory failure is when the patient has reached the state where their own ability to keep their head above water, so to speak, is insufficient. And so some of the things that we see with respiratory failure are a change in mental status. We will see a declining respiratory rate because they're tiring out. So if you have either of those two things, a change in mental status or a declining respiratory rate, you cannot use CPAP. You cannot use this treatment for a patient that is bradypneic. You cannot use this treatment for a patient that is severely hypopneic. it won't work, right? You may get a little bit of an improvement in tidal volume because of stenting open of bronchi and alveoli, but if the patient isn't able to breathe on their own sufficient to sustain life, this is not going to do the trick for them. That's a patient that needs to get airway management from you, if appropriate, OPA, NPA, and then they need to get BVMs with oxygen. Okay, so disadvantage number 2, IPAP equals EPAP with CPAP, right? So inspiratory positive airway pressure will necessarily equal expiratory positive airway pressure. So this is okay, except if you have a patient that has air traffic taking place. And this is something that we commonly see with our emphysema, chronic bronchitis, COPD patients. The problem with those patients becomes less about hypoxia and more about hypercapnia, or a buildup of CO2. They're unable to get CO2 out. And you can imagine that if I'm pushing continuously on the lungs and I have a patient that's already impaired from an expiratory state, that's not going to do them any favors in terms of solving their air trapping problem. So there's times when this may not be super helpful for patients that have COPD. I'm talking like your barrel-chested patient. That doesn't mean that you can't do it. It just means that you shouldn't expect it to be a panacea for that patient. Okay, so then a third disadvantage is that there are a finite number of mask sizes, right? There's no such thing as a expandable mask that we can expand and contract to fit perfectly. And so if one of the mask sizes that we carry doesn't fit the patient, or if none of the mask sizes that we carry fits the patient, then you can't do this, you can't use CPAP. Okay, another disadvantage is that once that mask is on, it's difficult for you to see what's going on in the patient's airway, right? So if they vomit, it may not be obvious to you right away that they're vomiting, right? If they bite their tongue and they start bleeding into their mouth, that may, again, not be immediately apparent to you. So this does lead to a little bit of a reduced ability to assess and have direct control over the patient's airway. And related to that is this doesn't isolate the patient's airway. So this is not really a disadvantage relative to any BLS treatment modalities, but from, if you had paramedics that might be treating this patient, the paramedics could perform endotracheal intubation, right? And so endotracheal intubation isolates the airway, it protects it. Even if the patient is vomiting, the vomit can't get into the lungs. That is not the case with CPAP. And so you do have to be very cognizant of the risk of aspiration of vomit or blood, or anything else that might be in the patient's airway. Lastly, one of the big disadvantages to CPAP that you'll see in actual practice is an increase in pain and anxiety. It can be uncomfortable for these patients. Oftentimes, patients that need CPAP feel like they're suffocating, and so putting something on their face makes them feel like they're suffocating more. Now, that is a transient feeling, and if you can get them to calm down and get them to trust the machine and get them to breathe through the machine, they're going to do better. But you may well have patients that when you put this on, they try to swat it away and they say you're suffocating. So just be aware of that. And if they just can't do it, they just can't tolerate it, well, then you can't use the therapy. All right, so let's talk about our indications for using this. So the number one indication as listed in the protocol is persistent respiratory distress. So if you have a patient who has respiratory distress that has resolved with our other treatments, like you gave them a neb and now they're no longer in respiratory distress, you're not using this, right? If you have a patient who no longer has respiratory distress, but instead has progressed to the point of respiratory failure, you're also not using this, right? So what the patients we're talking about are patients that are remaining in this state of respiratory distress, where they're struggling to breathe, but they're still able to do it. And so there's two broad categories of etiology that the protocols speak to when it comes to our use of CPAP. So the first one is what we could categorize as lower airway obstruction. So that's going to be asthma, COPD, and wheezing, right? Wheezing characterizes obstruction of the lower airway. That's present in asthma, it's present in COPD. And we talked about a few slides ago, right? The therapeutic benefits of CPAP there are to splint open those swollen or constricted bronchi and bronchioles, right? And so that's why we're going to use it for those patients. The second broad category is persistent respiratory distress of unclear etiology. We're going to talk about what they're specifically referring to there in a minute. Actually, they don't really specifically refer to anything. They're very oblique about it, but I'll break it down for you and make sure you understand what it is that they're indirectly getting at. So speaking first about asthma, COPD, and wheezing, again, this is lower airway obstruction, and CPAP is beneficial because it stents open and increases the lumen or diameter of those lower airway structures and optimizes gas exchange in the alveoli. For these patients, you don't have to do NEB or CPAP. You can actually do both with the product that we've selected. You are able to use inline nebulization with the CPAP to optimize your patient care. Now, I want to call to your attention that if you are doing that inline nebulization, what you're going to not notice is that sort of stream of mist coming up off of the nebulizer. The reason you're not going to see that is because the flow of air is just so fast that it just gets whipped right into the lungs. So you're not actually going to see that stream of mist coming off the nebulizer like we usually see, but that doesn't mean that it isn't working, and you'll be able to see the fluid, the medication in the nebulizer chamber disappear over time. So that's asthma, COPD, and wheezing. So then the second major category of indications here is persistent respiratory distress of unclear etiology. And so the big one here is acute pulmonary edema, which is a buildup of fluid in the lower airway. And you can see that here on this little picture. You have normal lungs without fluid, and then you have a buildup of fluid in the lungs, flooding the alveoli, decreasing the area available for gas exchange, and as well decreasing diffusion of gases across the remaining lung membrane. So CPAP is helpful for acute pulmonary edema in a number of ways. First, it improves diffusion of gases across the lung membrane by increasing the pressure that those gases have against that lung membrane. CPAP can also, for these patients with pulmonary edema, force water from the alveoli, so we can call that interstitial fluid, back into the systemic circulation, so directly decreasing the edema. And then finally, CPAP increases our intrathoracic pressure, decreasing preload, decreasing cardiac output, decreasing blood pressure, and further relieving fluid overload. So when it comes to acute pulmonary edema, CPAP really is a little bit of a silver bullet. It works in a number of different ways that are all extremely beneficial and helpful and kind of work together in synchronicity, and they have the kind of a synergistic effect together that is incredibly beneficial for these patients in APE. So these are your bread and butter for CPAP. And let's review, guys, just very quickly, what the typical APE patient looks like. So typical APE patients are extremely air hungry. They may well be hypoxic on room air. They will typically be in a great deal of distress. Often they will have a history of congestive heart failure. Not always, but often. Often they will have peripheral edema, right? So pedal edema, ascites, that's buildup of fluid in the abdomen. Hepatojugular reflux, that's a backup of blood into the JVD into the jugular veins when you push on the liver. So this is where your patient assessment skills really come to the fore. Typical blood pressure for a patient in acute pulmonary edema is high, really high. I'm talking 200s over 100s, very high. But you can also have a patient who is in pump failure that has pulmonary edema due to the pump failure, and those patients can have very low blood pressures. And so those are patients that you can't use CPAP on because of the pump failure and already the impaired cardiac output. So you got to be a little bit careful. But I'm going to tell you that the majority of these patients are not in that pump failure stage. That pump failure patient is a really, really sick patient. They need medics. They need an ICU. They're going to need inotropes and pressors and all kinds of things that we can't give them at the BLS level. But the majority of the pulmonary edema patients we see are not at that stage. They're not they're not that sick. They are still very sick, but they're not as sick as a patient whose heart is failing from. So again, typical APE patient is going to have very high blood pressure. They're going to want to sit up. If you lay them down, if you lay them flat, they're going to become much more distressed. They're going to say that they are sleeping with lots of pillows propping them up at night. Oftentimes, an exacerbation of acute pulmonary edema will come on in the middle of the night. It's called paroxysmal nocturnal dyspnea, right? They're laying down and their lungs flood. So this is the call you get at 2 or 3 in the morning for somebody who was laying in bed and they woke up feeling like they were drowning, right? And then this as well is what we see in the winter months, and this is a biggie. Hot weather tends to cause vasodilation because the body's trying to maintain homeostasis and lose heat to the environment. So it vasodilates to increase our dispersion of heat to the environment. Cold weather causes vasoconstriction because we're trying to keep our heat and shunt blood to the core. Vasoconstriction increases blood pressure, which is a problem if we have fluid overload. So the scenario I want to paint for you is, imagine you have a patient who you're treating for dyspnea and they're doing okay. You've got them on a non-rebreather and you take them to the hospital, and it's a cold winter night, and you bring them outside. They're in the stair chair on a non-rebreather. You bring them outside, and as you're taking them the short trip from their front door to the back of the bus, their respiratory rate goes through the roof, and they suddenly say that they can't breathe. And you listen to their lungs, and they have either rails all the way up on both sides, or even worse, a silent chest, because their lungs have completely flooded. Because what happened is you brought them out into the cold environment, their body vasoconstricted, and that forced all the fluid out into their lungs, and they flooded. This is a patient that very well could die if you don't get them on CPAP right away. So this is the time you're going to use CPAP. All right, so let's talk about other conditions aside from our lower airway obstruction and our APE patients. Because unknown etiology is a very broad term, right? So could anaphylaxis apply? I would say anaphylaxis is probably not a good indication for using CPAP, and let me tell you why. Anaphylaxis involves upper airway obstruction, and anaphylaxis, it can involve lower airway obstruction as well, but remember that anaphylaxis also involves distributive shock. And so if you have a patient that's already in or prone to going into shock, then decreasing their preload and dropping their pressure is kind of the last thing you want to do, right? So similarly, upper airway obstruction, croup epiglottitis, this is not a good indication for using CPAP. These are our patients with stridor, right, with a croupy cough. The reason is that there's very little benefit that you're going to see with CPAP. CPAP is good at opening up the lower airways because those airways are pliable, they're compliant. When we talk about upper airway obstruction, we're talking about epiglottitis or croup is laryngotracheitis, right? So it's inflammation of the larynx and the trachea. So the larynx and the trachea are not, they're hard cartilage rings. They're not prone to expanding elastically, right? So they're swollen, but the CPAP is not going to do much for that swelling. It's just going to kind of be pushing against a hard wall. So it's going to be of comparatively little benefit to those patients. Bronchitis, yes. You can use CPAP for bronchitis. Bronchitis is a form of lower airway obstruction. Remember, one half of the COPD dichotomy is chronic bronchitis, right? So if we're using it for COPD, then of course we can use it for bronchitis as well. Pneumonia or lung tissue disease, so drowning, for example, also okay. Yep, absolutely. Pneumonia frequently is a buildup of fluids in the lungs, in the alveoli, buildup of pus, and CPAP can help push that interstitial fluid back into the systemic circulation and improve the amount of lung tissue available for gas exchange. So good. COVID. Risk benefit here. There is a risk to the providers. CPAP is used to treat patients with COVID, but when we talk about aerosol generating procedures, CPAP is right up there as one of the most aerosol generating. So if you can possibly temporize the patient and get them to the hospital without initiating CPAP in the closed environment of the back of the ambulance and exposing everybody, then I think probably to everybody's benefit to do that. If you have a patient that needs it, then yeah, you can use it. Pneumothorax is a big no-no. With pneumothorax, the presumption is going to be that somewhere in the lung is a hole that's allowing air to escape into the space between the visceral and the parietal pleura, right? So if you then begin to push air down into the lung, it's going to come right out that hole, and it's going to make the pneumothorax worse and worse and worse and worse and worse. And that's the last thing we want to do for our patients, right? First, do no harm. Finally, overdose or other circumstances where we have disordered control of breathing, CPAP is not going to help for the reasons we talked about above. We don't have direct control over rate or tidal volume. This is patients who are breathing on their own. They're trying to breathe, and we're going to help them out. If they're not breathing on their own, you need to breathe for them. That's a BVM. Okay, so contraindications. Well, this really is going to be a review of what we've already talked about, because we've already gone through how this works and what we use it for. And so these are all going to be obvious to you at this point, right? So respiratory failure, for the reasons we just mentioned, CPAP is contraindicated. Asystolic blood pressure of less than 100, so hypotension. Again, CPAP is contraindicated. It increases intrathoracic pressure, drops cardiac output, drops preload. It's going to bottom the patient out. Airway obstruction could potentially make the airway obstruction worse. When we talk about airway obstruction, they're talking about foreign body airway obstruction. They're talking about vomiting. They're talking about maybe blood, something we would need to suction out. And so again, because CPAP reduces our ability to assess and treat those problems, then we can't use it. In terms of lower airway obstruction is actually an indication for using CPAP. So very clearly here, when they talk about airway obstruction, they mean the upper airway. Facial burns with possible airway involvement. There's concern there for swelling of the upper airway, and CPAP could irritate that tissue, make swelling worse, and it also decreases our ability to assess it. So for those reasons, we're not going to use it in facial burns with possible upper airway involvement. Trauma, there's concern for the potential to cause a pneumothorax because there could be some sort of a rupture in the integrity of the visceral pleura. If the patient's at an aspiration risk, so they're vomiting or they have an upper GI bleed, then you can't use CPAP because, again, this does not protect the airway and it puts the patient at a greater risk for aspiration. Finally, if you can't get an adequate mask seal or the patient just can't tolerate it, then that's a contraindication as well. And that would be a reason that you would just discontinue the therapy and get them to the hospital with either a BVM or a non-rebreather. All right, so in terms of our standard operating procedure for this, we have selected a device called the Mercury Medical FlowSafe 2EZ. It comes with a nebulizer, so you can nebulize medications, your albuterol, your ipratropium with it. It is a single-use disposable device, and it uses less oxygen in comparison with other products. With that having been said, I want to tell you guys, nothing blows through oxygen like CPAP. You will not believe how quickly this will empty a tank. It is ridiculous. So you need to either get this patient out to the bus, get multiple tanks into the scene, or even request backup if it's going to be an extended extrication, because this will blow through your tanks like you wouldn't believe. So with our device, each of these units have two modes. We have the CPAP only mode, and we have the CPAP and nebulizer. Generally, I would say if you have a patient that you're treating for your asthma, COPD, and wheezing, so your lower airway obstruction, I would use the nebulizer, right? I would nebulize those medications that are bronchodilators along with your CPAP. If you're treating for unknown etiology, I would probably go with the CPAP only mode unless you have a reason to believe that they would benefit from bronchodilation. So they could be perhaps wheezing. Remember that real life isn't as neat and tidy as our protocols and textbooks would have us believe. And so patients can have more than one thing going on, right? Somebody can have CHF and asthma. It does happen. There is the phenomenon of the cardiac wheeze, which can happen when you have a fluid buildup narrow the lumen of your bronchi and bronchioles and create a wheezing sound because of that reduced lumen. If you have a patient who has a cardiac wheeze, you give bronchodilators, remember that ipratropium and albuterol both are going to tend to make the heart beat harder and put out more blood, and that can worsen fluid overload. That said, CPAP also tends to reduce cardiac output by increasing intrathoracic pressure. So it's impossible to say in the abstract which of those effects would predominate in a given patient. So this is where clinical judgment comes in. So if you think that based on the patient's history and the other signs and symptoms that there's a chance that they have some sort of reactive airway disease and they would benefit from bronchodilation, go ahead and bronchodilate them, but reassess them, right? Reevaluate them after you start your treatment. And if they're getting worse, discontinue the neb, discontinue the CPAP, whatever you need to do to optimize their care. So airway pressure, which is what we're delivering with CPAP, right? Positive airway pressure is measured in centimeters of water. And this is conceptually, it's the height of a 1 centimeter square column of water that the pressure of the gas we're delivering would support. So typical values for CPAP are from 5 to 10 centimeters of water. And our device can deliver anything in that range from 5 to 10 centimeters of water. You'll know what you're delivering because there's a gauge, which is called a manometer, on the device that measures the pressure that it's putting out. And so you'll be able to see in real time what pressure is being delivered. You can adjust the pressure by very simply adjusting the flow on the O2 regulator. It's nothing on the mask or the device itself. It's all done at the site of the regulator. There is a yellow sticker on the device that will show you typical pressures that a particular flow rate should yield. So it'll say 10 liters per minute will give you this pressure, 12 liters per minute will give you this pressure, 15 liters per minute will give you this pressure. If you're using a nebulizer, though, some of the flow gets diverted to the nebulizer, and so you're going to need a higher flow in order to achieve a given pressure. And again, this is where the manometer comes in handy because you'll be able to see in real time exactly what pressure is being delivered. And one of the kind of neat things that you can do is engage in titration, right? The idea of titration is you can start with a lower value, see how that goes, then you can increase it, see if the patient does better, see if they do worse. If they do better, you can increase it some more. If they do worse, you can go back to what you had, right? So you can kind of adjust in real time and sort of play with what you have and see how the patient does. So you're going to use our equipment, of course, according to the New York City REMAC protocols and the manufacturer's instructions. We're going to be sending out, along with this video, a companion video from Mercury Medical, the manufacturer, that's going to take you through the specifics of the device, how it's designed to be attached, the labels, where everything is, that sort of thing. These are one-time use devices, so you're going to dispose of it after you're done. We will have them available in the supply area at our VAC to restock. You're going to make sure that your use of CPAP has been documented in ESO. The PCR needs to go in for QA/QI review as part of this program. So it's going to automatically get flagged when you document that CPAP has been used. And ops hopefully will get notified to order replacement equipment anytime this is done. We're going to work on a way to automate a notification to operations that CPAP has been used through ESO. Our initial order is sufficient to meet our expected use until we can get more, right? So we're going to have enough on hand to keep us in service until we can get more. So what's next? Well, now that we've gone through this presentation, you're able to go and take the online quiz that was sent out with this. After that's done, there's going to be a list of dates that you can come down to the base for a hands-on in service. So we'll have the equipment there live. We'll have an instructor there, and they will demonstrate it for you, and then you'll demonstrate it for them, demonstrate that you know what you're doing, and you'll get signed off. Once we've got a critical mass of people that have been signed off, then we'll designate what day will be our go live date for actually using these on the ambulance. And from that point forward, this will be standard of care for us. So we can't go live until we've got pretty much everybody trained, because once we go live, that creates an expectation that this is the care we deliver. And it's problematic if we have some people that can do it and others that can't. So we really need to get everybody able to deliver the care before anybody starts to deliver it. So that's the plan from here. I will say that I am happy to answer any questions or hear any feedback that you have on this. My email is my first initial and last name. So that's m.smith@ridgewoodvac.com, just like everybody else. And be happy to hear from you, be happy to answer any questions. It is very likely that I will be doing a lot of the hands-on in services. So I will hope to see you there for one of those. And if not, I'll see you on the ambulance. And I want to thank you for your time, and I hope you have a great day.